Hi, Dr. Brian Koffman at ASH 2013, continuing my discussion here with Dr. Neil Kay. And Dr. Kay, we were discussing the whole issue of not new clones arising, if I'm getting that, but very, very small clones without very sensitive techniques you might even miss are becoming predominant, and maybe it's the therapeutic pressures that allows one clone to take over. It may not be predictable. So help me understand what happens when somebody isn't 17p, then gets FCR or BR, and then relapses. Boom, they've got 17p now. That's not an unusual story. So
Sure.
Where did that 17p come from if it wasn't there before?
So sticking within the paradigm of, let's say, two clones, where one is one is a subclone, one is dominant. Over time, these clones, we believe now, are not new clones, but are clones that either over time or with therapeutic pressures, if you will generate new mutations. So they're available for things to happen, for things to change. And we now know that obviously 17p can occur within a subclone and become dominant, particularly after therapy, as you mentioned. But there are other mutations that are associated with drug resistance that are exclusive, we believe, from 17p or 17p influence. So it's probably the novel part of what's coming out of these more unique studies are that the therapeutic pressure is not necessarily generating just 17p, and it's not necessarily, at least in our opinion, generating new clones. It's just setting up a milieu where these mutations, new mutations can occur, and a subclone may now become dominant with specific therapies.
But we also know, and I saw papers along this, that 17p especially, and I keep coming back to that, is a marker for genomic instability, which would say it's more likely to mutate in a way that would get past the therapy.
I would agree, and to have a 17, there's no question that the theme of the tragic theme of having a 17p is patient walks on to therapy, predicts for poor response, very likely related to the genomic instability and the generation of additional mutations that make treatment so difficult for those patients.
Now, we heard a paper today from Dr. Berger, which says this may not be just a problem with chemoimmunotherapy, but maybe a problem with the TKIs and stuff. What was your take on that paper? Can you tell us a little bit about that?
It was a nice study, one that we need, where instead of now, as you mentioned, non-chemotherapy using an oral BTK inhibitor and studying patients over time, albeit those patients are relapse refractory and have seen.
So these were tough people.
These were tough.
Two 17Ps, one 11Qs.
Exactly. And of course there's genomic instability inherent in that. But nevertheless, Dr. Berger has documented that as you study these patients over time, they have what appears to be the emergence of new mutations. They're not necessarily related to the B-cell receptor pathway. They can be unique and are, again, associated with resistance to these novel therapies. This does also highlight a problem that many of us have been thinking about, in that while chemoimmunotherapy obviously has its own selective pressures, it's limited to 4 to 6 months of treatment generally, whereas with these newer single-agent oral drugs, patients are on these for months, if not years. And again, what is the pressure on the clonal evolution and drug resistance? It's hard to tell, but it is concerning.
So let me ask you the big question from a patient's perspective. What research, what kinds of approaches are you thinking to, as our knowledge grows? Obviously, we want a treatment that works long-term, not just a treatment that gets a remission and comes back with worse disease.
Right. Yeah, that is the $64 million question. I would propose, this is not going to be that earth-shaking, I think a lot of people have thought about this, that we should get in and get out as quickly as possible. And now with the wide range a very large menu of therapeutic opportunities, to be able to quickly reduce tumor burden would be attractive, in my opinion. And then if one is able to get the patient to minimal residual disease, to use another drug that has non-overlapping mechanism as compared to the original debulking of the malignancy, if you will, that can help eliminate minimal residual disease. So one can imagine, for example, 2 or 3 courses of chemoimmunotherapy, followed by perhaps several weeks to months of these oral signal inhibitors. So the opportunity to get a patient into a negative minimal residual disease, which is our best bet, that that individual would have at least a prolonged duration of response and hopefully not relapse for many years, would be the best. There are other opportunities after that, such as utilizing the graft versus leukemia effects, such as in transplant, which is not so easy to go through,
Right.
or the possibility of even the CAR T cells to help mop up the residual. So I just to really answer your question, I think we need to get in and get out quickly and not necessarily have patients on drugs for years, because I think it will be permissive for drug resistance.
Interesting. So that is a bit of a, because we're figuring out how to use these drugs, because there's been talk about CLL as a chronic disease, and you sort of take your blood pressure medicine, and you take your statin for your cholesterol, so now you'll take your TKI and just go on, which is the model we have in CML,
Right.
but you're saying that may not be a good model for CLL.
I would love to see that we could take a pill and that's it for the rest of your life. And maybe that will be the case. I'm not saying it won't, but it's worrisome that these drug resistance patterns have been seen clinically.
Mm-hmm.
We have had cases of Richter syndrome occur on signal inhibitor therapy, and the global genomic analyses, which are showing the emergence of subclones that can be associated with drug resistance, are particularly worrisome. And perhaps that makes it distinct from CML. I think CLL clearly can be said it's not CML. It's a very different disorder. It doesn't have that single key genetic abnormality that CML does. So I think we have to think a little differently.
Yeah, I hate, I have a smart cancer, and it's much better to have a dumb cancer.
Well put.
Yeah.
Well put.
So any final thoughts or things that you would want to tell the CLL community about ASH or on any area that you wanted to, for a minute or two, yeah?
This ASH has really firmed up the widening opportunities for treatment, and I believe that it sets the stage perhaps for the next 3 or 4 or 5 years to refine how we're going to use these oral inhibitors alone or in combination. I think the descriptions of these engineered T cells that are honing in on leukemic B cells.
That's the CAR T therapy. That was very impressive.
That's going to move us
Dr. Porter and others, yeah.
Absolutely, Carl June's work.
Yeah.
That's going to move into more extensive use as the targets are refined using genetic engineering. The application of the global genomic analyses, these methods to follow patients, I think will be not only helpful in terms of what is the clonal architecture and evolution, but also be of prognostic importance for patients, and I think you're going to hear more about that. We are getting better at prognosis. The models are out there. I think that's better news for the CLL patient, because at least one can predict with more accuracy the clinical pace and course of a given patient. So I think that's also an exciting and continuing development in the world of CLL.
Well, thanks so much for what you're doing and the whole team is doing there. There's so much going on. And I'm just going to make my usual pitch to say the only way that any of this moves forward is if we get patients in clinical trials, because we're not there yet. And how we use these meds and what we do is going to depend on clinical trials. And the only progress we've made over the last couple of years is because of the brave patients who jumped into those clinical trials. So I'm going to make that pitch. Thanks so much. Thank you, Dr. Kay.
Thank you.
Yeah.